I want to start by just welcoming everyone here today, fellow faculty, staff, students, family members and friends of the Hakim and McLaughlin clans, and of course our speaker, Dr. David Williams. It's wonderful to have Anne and John here today and their daughters. We're thrilled you can make it, and we really appreciate Dr. Hakim flying in for the occasion. It's been a long time since we've all been together. The Catherine McLaughlin Hakim lecture is funded by Dr. Raymond Hakim to honor Catherine, a 1970 graduate of the sociology department here at Emmanuel College. The lecture series began about 10 years ago, and the mission of it was to bring top scholars to our campus, talking on a range of issues, but all tied to the issue of social justice. Dr. David Williams certainly fits that bill. Dr. Williams is the Florence Sprague Norman and Laura Smart Norman Professor of Public Health and Chair of the Department of Social and Behavioral Sciences at the Harvard T.H. Chan School of Public Health. He also holds positions in Harvard's Department of African and African American Studies and in sociology. We're not going to forget sociology. And prior to his appointments at Harvard, Dr. Williams was at Yale and the University of Michigan. He was elected to the National Academy of Medicine in 2001, the American Academy of Arts and Sciences in 2007, and the National Academy of Sciences in 2019. Dr. Williams developed the Everyday Discrimination Scale, which is the most widely used measurement of discrimination in health studies. His research has been funded by the National Institutes of Health, the World Health Organization, and numerous other national and international funders. His work covers the United States, Canada, the Caribbean, South Africa, and the United Kingdom. When I tell you that this is really just a very, very brief summary, it's really just the tip of the iceberg. I really mean it. I just would like to say a few words about the Catherine McLaughlin Hakim lecture series, which was started back in 2011. And then I'm going to hand it over to Dr. Hakim for a few minutes. We began with Mary Waters, a sociologist at Harvard, who spoke at that point on the disproportionate and overwhelming impact of Hurricane Katrina on lower-income Black residents of New Orleans. We also have had Peggy McIntosh as part of the lecture series talking about white privilege and the invisible knapsack. I hope that is something that many of you have read, both in sociology classes and in other classes across the campus. We had David Cunningham, formerly of Brandeis University, I think he's now at UNC Chapel Hill, talking about white supremacy. It is not that we only invite speakers to talk about the issue of race. It is rather that whatever topic we choose has to discuss race. It is built into everything that is part of American society. When I was preparing the welcoming remarks for Peggy McIntosh's talk, this was just the other day, and I was looking back at what I'd said, I talked about the shooting deaths of unarmed Black men from Ferguson to Staten Island to Atlanta. That was back in 2014. Today, the geography is different. Minneapolis, Glynn County, Rochester, but the results are the same. Just the other day, the New York City Board of Health declared racism a public health crisis, something the CDC had done several months ago. When our department was discussing who should be the latest speaker in the series back in the spring of 2019, right, so this is way before COVID, my colleague Ivy Kroll, who's here today, suggested Dr. Williams, based upon the ongoing racial inequalities and injustices that we saw all around us. That was all before the COVID pandemic and the drastically unequal suffering that was in existence, but has so come to the fore in the light of COVID. None of these racial injustices are new, but they have been brought to the forefront in a way that we can no longer ignore. I don't need to tell you, Dr. Williams, your work is more important now than ever, and maybe people are finally willing to listen. On a last note, I would like to say a word of thanks to Dr. Hakim, who's made this lecture possible, and he's going to say a few words. I say it every year, and I mean it every year. These lectures matter. They make a difference, and we cannot hold them without your support. I sincerely hope that these lectures are doing justice to the kind of person that Catherine was, that they are doing justice to Sister Maria Augusta Neal, who taught and inspired Catherine, and they are living up to the memory of both of these women. Thank you very much. And now over to Raymond. Thank you.
Thank you very much, Andy, for this wonderful introduction. I'm so proud that we've developed this lecture in honor of Catherine, or in Catherine's name, because she really loved Emmanuel College and loved sociology program with which she was affiliated with. In fact, I don't know whether it's relevant, but we got married when she just finished her third year on sociology. But she really insisted on finishing the program and graduating, and she did that remotely. So she was very proud of the Emmanuel College and sociology department and what she learned, and that helped her throughout her life with us. I'm sorry that she's no longer with us, but I also want to welcome her sister, brother-in-law, and her two nieces that are here, that we hope will also enjoy and cherish this lecture. And I'm very proud that Dr. Williams has accepted this invitation, and look forward to his talk about issues that really were important also to Catherine. Thank you for your time, and thank you for
So it's truly an honor and a privilege to be here with you today and to honor sociologists. My doctorate is in sociology from the University of Michigan, and sociology shapes everything that I do. It gives me the lens through which I look at the world. And it's truly a privilege that it took me, this is my 15th year living in Boston, the first time I've stepped onto the Emmanuel College campus, although I drive by it all the time. So I know that there's a place called Emmanuel College. I've seen the sign, but thanks for the invitation, and I hope this will not be my last time visiting the campus. And it's been a pleasure for me to meet Dr. Hakim and just to share with him and to learn a little bit about his wonderful wife and what she did and what her values were. And I think it's a really powerful inspiration for what I will try to do today. I'm going to jump into my talk so that we have time, hopefully, for maybe some questions at the end. And I want to talk about how can we best understand. I think I can take my mask off. Is that correct?
I think that's fine.
Okay. Far enough
Yes,
from
that's
others?
right.
Okay. Understanding and effectively addressing, this is wonderful, racial and ethnic inequities in health, and socioeconomic inequities as well. The same issues matter, well, there's overlap, but there's large socioeconomic inequities as well. And I want to begin where the world is right now in thinking of COVID-19, and I will show you the racial inequities in deaths from COVID-19. This is not all deaths. This was deaths through March 2. At that time, 520,000 Americans had died. You can add 200,000 more to that today. And what is shown here, compared to whites, you can see the disadvantaged groups. Native Americans have a death rate 2.2 times higher, and Latinos 2.4 times higher, and African Americans twice as high, and Pacific Islanders 2.6 times higher. The Asian population has a death rate similar to that of whites. When I talk about COVID-19 and the racial differences in death rates, sometimes people assume that it means that most of the people who've died from COVID are persons of color. That is not true. Because of the differences in population, the majority of people who have died are white, almost 300,000. The 520 deaths were of whites, and you can see 89,000 Latinos and 73,000 African Americans. So it's really important to make the distinction between the rate of death and the total number of persons who have died. COVID-19 has had a dramatic negative impact on the health of the United States population, something that we haven't seen for a long time. Reports from the CDC shows that there has been a marked decline in life expectancy in the United States at birth of almost 2 years as a result of the COVID-19 pandemic. We have not seen a decline in life expectancy of that magnitude since the Second World War. From 1943 to 44, there was a similar decline. We haven't seen one like that. And that decline is not uniform across the population. The largest decline has been for Hispanic males, a 3.7-year decline in life expectancy, 3.3 for African American males, 2.4 for African American females, 2 years for Hispanic females, 1.3 years for white males, and 1.1 year for white females. And COVID-19 is just shedding the light on a larger problem. It's not a surprise to us who work in the field that there were racial ethnic disparities with COVID-19, because there are racial ethnic disparities with virtually any disease condition you look at. And this is, puts it into perspective. There's good news and bad news in the data here. This is life expectancy at birth for blacks and whites from 1950 to 2020. Those are the only two groups that we have racial data going back that far. And what you could see, there was about an 8-year gap in life expectancy in 1950, and there's a 6-year gap in life expectancy in 2020. So we still have a long way to go. The good news is life expectancy has increased, generally speaking, except from between 2010 and 2020, and that reflects the impact of COVID in 2019, over time for both racial groups. So things have gotten better. Life expectancy has been getting longer for all, and that's a wonderful thing. But the magnitude of these differences are striking. Look at the life expectancy of whites in 1950, 69.1 years. And let's ask, how long did it take for African Americans to reach the health that whites had in 1950? 1990, African American health. That's 40 years later. Two groups living in the same society with a huge gap in health like that. What drives these large racial inequities in health? Well, as a sociologist, I first think of socioeconomic status. Whether measured by income, education, occupational status, or wealth, socioeconomic status is the single biggest predictor of variations in health in the world. In virtually every country of the world where we have data, persons of high levels of income, education, occupational status have better health than those. And that doesn't matter whether the country has a universal health system or not, these patterns are there. And if socioeconomic status is such a powerful predictor, there are large racial ethnic differences in socioeconomic status. And I'll give you an example of that. This is median household income in the United States in 2018 by race. But I'm going to translate that data in a way that you can not miss the point. So as the same data, I'm just standardized on the household income of whites as $1. For every $1 of household income white households receive, Asian households receive $1.23. Two important points to make sense of that data. One, Asian households is a racial ethnic group with the highest proportion of immigrants. Almost 70% of Asians in the United States are immigrants, and they've come to the United States with high levels of education. Asians have markedly higher levels of education than whites. But a second and really important point is that Asian households are more likely to be multi-generational than any other racial group. So there are more persons contributing to household income. So if you use the per person or per capita measure of income, whites would have the highest level of per person income in the United States. But let's look at the historically disadvantaged groups. In 2018, for every dollar of household income white households receive, Latino households receive 73 cents, and African American and Native American households receive 59 cents. You know what is stunning about the 59 cents figure in 2018? That's identical to the racial gap in income in 1978. I did not misspeak, you heard me correct. Why did I pick 1978? 1978 was the peak year of the narrowing of the black-white gap in income as a result of the anti-poverty policies and the civil rights policies of the 60s and 70s. The gap had shrunk to 59 cents. And in 2018, it is still 59 cents. Has it been stuck at 59 cents over time? No, it got worse throughout the decade of the 1980s. And it was in the mid-1990s that it got back up to 59 cents, and it's been a penny up and down from the 59 cents figure since then. Most of my students think that we have made more progress in reducing racial gaps in economic status in the United States than that. And as bad as those data look, they dramatically understate the racial ethnic differences in economic status. Why do I say that? Well, income captures the flow of resources into the household, but it tells us nothing about the economic reserves that households have to cushion shortfalls from income. We get that from data on wealth, which is home equity, which is checking accounts and savings accounts and financial investments and so forth. And if we look at the latest Federal Reserve Board data on wealth, for every dollar of wealth that white households have, black households have 10 pennies and Latino households have 12 pennies. When you are low in income and low in wealth, we may all be in the same storm of the pandemic, but we're not all in the same boat. And some boats are better equipped to weather the storm than others. When you are low in income and lack wealth, you can be one paycheck away from being homeless and one paycheck away from being able to feed your family. When my career started, most researchers thought that the racial differences in health were simply a function of racial differences in socioeconomic status. So if you compared, for example, blacks and whites at the same level of income and education, race wouldn't matter. Life is more complicated, and I'll show you national data for the United States. Life expectancy at age 25. At age 25, how long will the average black and white person live? The average white person will live 5 years longer on average than the average black person. However, if we look within whites by education, whites with a college degree live 6.4 years longer than whites who have not finished high school. The power of socioeconomic status. And this is important because most people are unaware of this. The socioeconomic gaps in health in the United States are generally larger than the racial ethnic gaps in health. There's a 5-year gap by race. There's a 6.3-year gap within the white population by education. It's similar with income. And for African Americans, there's a 5.3-year gap between the best of African Americans, college degree or more education, and those who have not finished high school. So should we just look at socioeconomic status and abandon race? Not so fast. Why? Because at every level of education, it's also true for income, race still matters. So white high school dropouts live 3.1 years longer than black high school dropouts, and the gap widens as education increases, with the best of African Americans, those with a college degree or more education, having lower life expectancy than whites with a college degree, than whites with some college, than whites who have finished high school. So what do these data tell us? They tell us that there's something powerful about income and education that matters for your health regardless of your race. But it also tells us there's something else about race that matters for health even after you've taken income and education into account. And so researchers have been asking for the last 25, 30 years with good empirical data, could racism be a critical missing piece of the puzzle to understand the patterning of racial differences in health? And I want to talk about the difference between individual versus institutional or structural or systemic discrimination, words that people use today. And when I think of racism, I think less of the individual beliefs and behavior of individuals, but I think of racism as a societal system. A system that categorizes and ranks and differentially allocates resources to groups regarded as inferior. And you're saying that's all very abstract. So I'm going to try to break it down very simply for you today to talk about one mechanism of upstream institutional or structural racism, and that's residential segregation. A policy developed in the United States in the late 19th century, was strengthened in the 20th century as blacks moved from the South to the North, has been locked in place since 1940, has been illegal since the mid-1960s, but the structure put in place still persists. John Sell was a historian at Duke University. He wrote a book about the origins of segregation in the US South and South Africa. He actually showed that the framers of apartheid got the idea of apartheid from the United States. They looked across the Atlantic and saw how well segregation was working in the United States, and they said, brilliant, we can implement that in our country. Importantly, Sell argues that segregation was one of the single most successful domestic policies of the 20th century in the United States. And you're saying, what does segregation really do? Why is it so powerful? I want to describe to you how segregation works. Imagine a burglar at midnight slips into a community bother anybody, but as soon as that burglar shows up, valuables disappear, like quality schools and safe playgrounds and good jobs and a healthy environment and safe housing and access to high quality transportation and healthcare. Research in the United States reveals that all of these factors vary by place, vary by the neighborhood where you live. In public health today, researchers say your zip code is a stronger predictor of how long and how well you will live than your genetic code. Let's look at some empirical evidence. Two Harvard sociologists, William Julius Wilson and Robert Sampson, studied the 171 largest cities in the United States and said because of segregation, there's not even one city where whites live under equal conditions to those of blacks. And they have this striking statement: the worst urban context in which whites reside is considerably better than the average context of black communities. If someone's paying attention to my citations, that's a 1995 publication. Have things gotten better over time? So I'm going to draw on the work of Dolores Acevedo Garcia at Brandeis University. She has created a neighborhood opportunity index, ranking every county in the United States on almost 30 different indicators of access to opportunity for kids. Things like the quality of schools and high school graduation rate and income level and home ownership rate and employment rate and the quality of the environment, the air, the water, the soil, exposure to hazardous waste sites, and resources for health like green space and healthy food outlets and walkability. These are just a few examples of the nearly 30 indicators that she has put together in an index called diversitydatakids.org. It's a website that you can do it. This is what she's found. If we look at the 100 largest metropolitan areas in the United States, and we ask the question, who lives in the very low and low opportunity neighborhoods? 2 out of every 3 black children are growing up in a very low or low opportunity neighborhood, as is also true for 58% of Latino kids, 53% of Native American kids, and about 1 in 5 white and Asian kids. If we ask at the opposite end, who lives in high opportunity neighborhoods? Well, it's almost 2/3 of white and Asian kids, and only about 1 in 5 black and Latino kids. So opportunity varies markedly at the neighborhood level in the United States. In fact, research finds that the racial differences in income and education we find are driven by opportunity at the neighborhood level. Here's a study by David Cutler and colleagues. He's a Harvard economist, using national data for the United States, using fancy, rigorous methodological analyses. He shows statistically, if you could eliminate segregation in America, you would completely erase black-white differences in income, in education, in unemployment, and reduce black-white differences in single motherhood by 2/3. All of those striking differences are driven by opportunity at the neighborhood level. One more study, another Harvard economist, Raj Cherry. He has done an intergenerational analysis. He's asked a simple question. Let's look at black and white children who start out life in the same level of household income. How are the kids doing in the next generation? And he finds in 99% of census tracts, a census tract is a geographic area, in 99% of census tracts in the United States, black boys have lower earnings than white boys, even when they started out at the same level of household income. Why? They live in neighborhoods that differ in opportunity. Black boys do as well as white boys if they live in neighborhoods with good resources, but those neighborhoods are hard to find in these United States. What do these data tell us? They tell us that racial inequities in income and education and wealth that matter profoundly for health do not reflect a broken system. Instead, they reflect a carefully crafted system functioning as planned, successfully implementing social policies, many of which were rooted in racism. They are not accidents, they're not acts of God, they're not random events. They illustrate the powerful ways in which these upstream mechanisms of racism have produced a truly rigged system in the United States. And what research finds is that when you are lower in economic status and you live in disadvantaged segregated neighborhoods, you are exposed to higher levels and greater clustering of stressors, economic stresses, psychosocial stresses, physical and chemical stresses, and all of these take a toll. And on top of those stressors, there is the stress of racial discrimination. This is the Everyday Discrimination Scale that was mentioned in the introduction. It's one of the measures I developed back in the 1990s to try to capture discrimination and to document its effects on health. And what is striking about it is not dealing with the big stuff. It's talking about being treated with less courtesy and respect than others, receiving poorer service than others in restaurants or stores, people acting as if they think you are not smart, you are afraid of you. Just to give you a sense, I have a student doing a meta-analysis of studies of discrimination. There are more than 450 published peer-reviewed papers from around the world. You looking at the Everyday Discrimination Scale. I have a student in Korea studying everyday discrimination in Korea. Just to illustrate, higher levels of everyday discrimination have been associated with incident that new cases of metabolic syndrome, of cardiovascular disease, of breast cancer, of type 2 diabetes, of a number of risk behaviors that increase risk of death, a number of subclinical indicators of heart disease like coronary artery calcification, intima media thickness, visceral fat, heart rate variation, AFib, adult onset asthma, higher blood pressure, poorer sleep quantity and quality, a number of subclinical indicators of disease like inflammation, cortisol, telomere length, allostatic load, a global measure of biological dysregulation, higher levels of obesity, less engagement with the healthcare system, and higher rates of mental disorders and psychological distress. This is just a sample of, and it shows you the range of physical and mental health indicators that are driven by exposure to the stress of discrimination. And what are the consequences of discrimination plus all the other stressors? Scientists are using the words accelerated aging or premature aging or biological weathering. And what they are documenting today in research is that more studies have been on African Americans. We believe this is to be true for other populations of color as well, but that African Americans are literally aging biologically more rapidly than whites. At the same chronological age, some studies show with national data looking at biomarkers, blacks are 10 years older than their whites who are the same chronological age. Why? Because if you live in a bad environment, your age is not only capturing how long you have lived, your age is also telling us how long you have been exposed to bad environmental conditions and how physiologically compromised you have become as a result of such exposure. And one of the consequences of that is the earlier onset of disease. Arlene Geronimus from the University of Michigan is the one who coined the term biological weathering. And what she is saying is that the cumulative exposure to all of these stressors and coping with these stressors leads to this biological dysregulation that triggers the earlier onset of disease. I'm showing you one outcome from CDC. This is the earlier onset of high blood pressure. Let's look at age 50 to 64, for example. By age 50 to 64, 41% of whites have hypertension compared to 61% of African Americans. And you can see that pattern emerging at younger ages as well. So I've talked about the problem. What can we do about it? There's a lot we can do. So first, we need to build more health into the delivery of medical care. And the first strategy within that domain is ensuring access to care for all. Medical care will not solve all of the racial inequities in health, but it can solve some of them. And I want to give you a great example from the state of Delaware. Delaware implemented a statewide colorectal cancer screening program. And then 2 years after, they opted to a colorectal cancer treatment program that everyone in the state, up to 6.5 times income of the poverty level, could get colorectal cancer screening and treatment provided by the state. And they did outreach efforts as well so that disadvantaged poor communities, Latino communities, African American communities would know about it. What was the result? You see, in 2002 is when the program started, and you could see by 2009, increases in screening rates for African Americans, even larger for the increases for whites, both groups increased. They eliminated the disparities in screening for colorectal cancer. You see wonderfully declines in incidence rates, that's new cases of colorectal cancer for African Americans and for whites. They equalized the incidence rates, and a near elimination of the mortality difference, marked declines for African Americans and for whites. And you know what was most striking about the program? The program saved the state of Delaware $1.5 million a year as a result of the reduced incidence and early diagnosis of the disease. So they actually save money by providing care for all. This will not work for every health outcome, but we need to identify those health outcomes improved access to care would address. What else do we need to do in building more health into the delivery of health care? We need to eliminate inequities in the receipt of high quality care. Back in 2003, the Institute of Medicine at the time, now called the National Academy of Medicine, issued a report was entitled Unequal Treatment. I served on the committee that produced that report back then, and what we found was across virtually every therapeutic intervention in the United States, from the most simple procedure to the most complicated, blacks and other minorities receive poorer quality care than whites. I'll give you an example of a recent study that doesn't document why it happened, but document the pattern. This is a paper published just last year. Looked at 1.8 million hospital births in Florida from 1992 to 2015. And when cared for by white doctors, black babies are 3 times more likely than white newborns to die in the hospital. The disparity is cut in half when black babies are cared for by a black doctor. What is driving that? And that's just one example. We think the most powerful driver is likely to be unconscious or unthinking discrimination. The United States is a country with arguably the best trained medical workforce in the world. And the overwhelming majority of physicians wake up every morning to do their best for all of their patients. But yet, they are producing a pattern of care that is discriminatory. How is that possible? We think the phenomenon that drives it is what's called implicit bias or unconscious or unthinking discrimination. I like to tell my students that I think of myself as a prejudiced person. And I tell them I think of myself as a prejudiced person because I would like to think of myself as a normal human being. And if you're a normal human being, you're probably prejudiced. I didn't say you were racially prejudiced because this is not just about race. It's about how we process all of the complex cognitive data we face every day. Every culture, every community, every society has in-groups and out-groups. And what the research finds, based on where you were raised and what you were taught, when you meet someone for whom you have negative assumptions for the social group to which they belong, you will treat that person differently. That is, you will discriminate against that person. It's automatic. Blink your eye for me. Blink your eye, right? It occurs in 1/3 of the time it takes to blink your eye. 100 milliseconds. A millisecond is 1,000th of a second. It takes about 300 to 400 milliseconds to blink your eye, and it occurs in 100 milliseconds. You know that person, and you will treat them differently without your own awareness if there are those negative stereotypes in your mind. And so you may not have racial prejudice, but I would ask you, what are the categorical negative beliefs and assumptions and stereotypes you may have about fat people, about gay people, about poor people, about women, about all people? You get the point. Or people from this country or that country. These same processes operate. Now, there's a huge industry in the United States of doing implicit association tests, and I think it's a great test to do to raise awareness levels as a solution to addressing the problem of inequities in health. What the research indicates, though, is that the test, while it raises awareness level, it has limited impact on reducing implicit bias and even less impact on reducing explicit bias. I like to talk to people about the Divine solution. Professor Patricia Devine at the University of Wisconsin has developed a model program, and it's not a 2-hour workshop, it's a 12-week program. People go to a class once a week for 12 weeks. They get exercises, they got practice sessions, and it's a comprehensive program, and it puts together all of the strategies that have been shown to be effective in reducing implicit bias. People implement them, they get homework assignments to do it. So what I'm saying is, going online and taking the test doesn't solve the problem. It really takes time and effort and energy, and Professor Patricia Devine's work shows it's possible, but not with what most universities and companies in corporate America are doing. What else do we need to do? Well, we certainly need to diversify the workforce to meet the needs of all patients. Here is a study done in Oakland, California, a randomized controlled trial, took 1,300 African American males, gave them a coupon and $50 to go and get a screening, health screening at a Saturday clinic at a nearby hospital. When they got to the hospital, they were randomized to see a black doctor or not. So all the participants were black. Those who saw a black doctor were 29% more likely to talk about other health problems, more engaged, 47% more likely to do screening for diabetes, 56% more likely to get a flu vaccine, 72% more likely to do screening for cholesterol. So with racial concordance, there was absolutely better engagement and better utilization of healthcare. As a nation, we face a challenge. The Association of American Medical Colleges had a 2015 report that documented in 2014 there were fewer African American males in the first year of medical school than in 1978. In the mid-1960s, 2.9% of all practicing physicians in the US were black. In 2019, 5% of practicing MDs are black, 6% Latino, 0.3% Native American. We have a long way to go. While we get there, I have good news. There was a study done also in Northern California that showed among patients with HIV, there were racial disparities in general in this study. However, there were no racial disparities in the receipt of the appropriate therapy, in participants following through on the physician's recommendation, and on the medication working to do what it was designed to do for persons who were high on cultural competency. And here are the measures on the cultural competency scale. It was physicians who agreed that family and friends were as important to health as doctors, who agreed that social history contributed to how they cared for their patients, who agreed they were familiar with the beliefs their patients had, who said, I asked my patients about alternative therapies they use, who said, I find out what my patients think is the cause of their illness, who indicated they involved their patients in decisions about their health. The study didn't tell us how to get there, but it shows us that physicians who are, and I should broaden this, my wife's a nurse practitioner, she always said, when I talk about physicians, I need to talk about healthcare providers. Healthcare providers who really respect their patients, who engage with their patients, who understand and listen to their patients. No racial disparities existed for those who had that kind of orientation. So we've talked about what can be done within healthcare. What else can we do? We can also provide care that addresses the social context. The World Health Organization asked the question, what do we accomplish if all we do is treat illness and send people back to live in the same conditions that made them sick in the first place? Right in Boston, at the Boston Medical Center, more than 30 years ago, was born the Medical Legal Partnership, where a primary care provider at a pediatrics unit could refer a patient to a number of specialists. One of the specialists were on-site attorneys, lawyers, as part of the medical team to solve the problems that patients have. Imagine a mother coming to her pediatrician with a child with asthma. All the asthma medication in the world will not help that child to breathe symptom-free if that child is going to go back home and face the same housing conditions that led to the asthma problem in the first place. So getting an attorney to intervene with the landlord about the asthma problem is part of a comprehensive approach to medical care. I want to share with you two of my heroes. Jack Geiger, he died last year, a great American hero. He started the community health center movement with the first community health center in Boston, in Columbia Point, back in 1965, and the second one in Mississippi Delta in 1966. And in Mississippi, what did he do? Facing the poverty and discrimination in Mississippi, he would write prescriptions for malnourished children in Mississippi. They were filled by the local grocery store, and they were paid out of the health center's pharmacy budget. Because if the kids don't have good nutrition, what are you doing in terms of providing care? Another of my heroes, a nurse practitioner, Anita Martin. I met her in Wichita, Kansas, visited her center twice. African-American female, wanted to do something for her community, and she single-handedly raised money from the business community to build a new health center in her community. And I walked into the health center and I thought I was walking into an African art gallery. That's how the walls were so well decorated with pictures. What I want to emphasize is what she did within that center. She wanted to demonstrate to every patient who came in that your insurance coverage and your economic resources has absolutely nothing to do with the care that you will receive here. And so what did they do? No questions were asked about what insurance do you have or how you will pay for the care today until you had received all of your care. It was the last stop. At the end of care, they would then discuss, do you have insurance? If you don't, how are we going to pay for the bill? And would try to work out something. And came up with creative ways. Clients could pay for services by volunteering at the clinic. $10 deducted off of your bill for every hour served. You could also get $10 deducted off of your bill for every hour spent in a health education class where you're learning preventive strategies to take care of your health. And they took me to a room called the Stork's Nest that was a place that had everything an expectant mother would want for her baby. And if she stayed on time with her prenatal visits, she accumulated points that she could cash in towards the end of her pregnancy to get stuff that she would need for her baby. What am I illustrating? What two individuals did to make a difference in Jack Geiger's case for the world. He has organized two medical organizations he founded. Both of them won Nobel Peace Prizes. And then what Anita Martin did to make a difference for her community. What else can we do? Well, we need to build community immunity for future pandemics. We need to minimize, neutralize, and dismantle the systems of racism that create inequities in health. That means we need to enrich the quality of neighborhood environments. We need to increase economic development in poor areas. We need to improve housing quality and the safety of neighborhoods. What would communities of opportunity look like? Here are a range of strategies, and I don't have time to talk about all of them. I'll talk about two of them. One is investing in early childhood, and the other is improving neighborhood and housing conditions. And those things may sound difficult, but I want to show you the evidence. The Carolina Abecedarian Project is a project that began in Chapel Hill, North Carolina, where they took poor kids, 80% of them African American, randomized them to an early childhood development program, put them in a safe, nurturing environment with good nutrition, good pediatric care, good intellectual stimulation. By age 21, those who got the program compared to the control group, better health, more active lifestyle, greater educational success, greater vocational success. By the mid-30s, lower levels of cardiovascular disease and metabolic disease. Here's the systolic blood pressure differences between the treatment group, those who got the program, and all it was what you offered them birth through 5. There are ripple effects on educational outcomes, on job outcomes, on health outcomes down the road. Lower levels of obesity at age 35 linked to a program you got birth through 5. It's remarkable, and there are studies that show for every $1 invested in early childhood programs, a preschool study in Ypsilanti, Michigan shows there's a $17 return to society. So it's really an investment in our future with programs like that. Improving neighborhood and community conditions. Many people think it can't be done, but there's high quality evidence. Moving to Opportunity took public housing residents, randomized them to move to less poor neighborhoods, no health intervention. 10 to 15 years later, what did this paper in New England Journal of Medicine show? Lower levels of obesity, lower levels of severe obesity, lower diabetes risk. What did you do? Simply change the neighborhood. Can we transform existing disadvantaged neighborhoods? Yes, we can. Purpose-built communities is an example. Come with me to East Lake, Atlanta. East Lake Meadows in 1995. It's an African-American public housing project. Has a very high crime rate. 90% of the families who lived in that public housing project were victims of a felony every year. Dilapidated housing. Only 13% of adults employed. One of the worst performing elementary schools in the state of Georgia, the nearby elementary school. This is the villages of East Lake today. I visited it about 4 years ago with one of my colleagues, Jack Shankoff. There's been a 90% reduction in violent crime, high quality private managed housing, all able-bodied persons are employed. The school, although 60% of the students qualify for reduced price lunch, is one of the top 5 performing schools in the state of Georgia every year. It can be done. What's the purpose-built model? To address all the challenges faced by poor communities simultaneously, to develop a comprehensive integrated program, emphasis on high quality education, quality mixed income housing, and the services that enables communities to survive. And do you know what? Purpose-built communities, led by Shirley Franklin, the former mayor of Atlanta, is the chairman of the board. They are providing free technical assistance to any community in the United States who wants to replicate their model. And there have been 22 purpose-built sites in the United States today. It may not be perfect, but it shows that it can be done if we make up our minds to do it. And if we did that, the creation of communities of opportunity to reverse racial injustice will be beneficial to people of all races. Policies that benefit communities of color will improve conditions for everyone, including many working class and poor whites. So what's holding us back? What's the elephant in the room? There are 3 major challenges I want to end on. We need to raise awareness levels. Most Americans are unaware that there are even racial inequities of the magnitude I've just talked about today. And if you don't know there's a problem, you're certainly not mobilized to solve it. Secondly, we need to build a science base to develop the political will to do something about it. And most importantly, and maybe most challenging, we need to build empathy. W.E.B. Du Bois was an African-American social scientist of the late 19th and early 20th century. In 1899, he published a book entitled The Philadelphia Negro. He has a chapter on Negro health, talks about the racial disparities back in 1899 in Philadelphia. And as he came near the end of the chapter, he penned these words: "The most difficult social problem in the matter of Negro health is the peculiar attitude of the nation toward the well-being of the race." And he continued, "There have been few other cases in the history of civilized peoples where human suffering has been viewed with such peculiar indifference." What Du Bois called the peculiar indifference, scholars today call the empathy gap. Here's a review paper, documents on every continent in the world. There is an empathy gap. We human beings have a stronger empathic. We feel the pain of someone of our own racial group compared to someone of a different group. And that's been documented on every continent in the world. Here is a study that shows among 5-year-old white children, no racial bias. They show a person being stuck in the arm with a needle, whether it's black or white. They see the black person and the white person experiencing the same amount of pain. By age 7, there's a tendency to see the white person experiencing more pain than the black person. By age 10, it's pronounced. What reduces the empathic gap in brain activity? Individuation. That is, not focusing on the group to which a person belongs, but trying to understand that person as an individual. Secondly, if you see ourselves as on the same team, we are working together for a larger cause. And they also find, research finds that greater interracial interaction in one socialization among adults leads to more empathy. But we need to think of ways scientifically of how we can best close the empathy gap in real world context so that we can make a difference. We need to build a science base that will guide us in identifying what framings we need to use. In other words, how do we tell the story in a way that connects emotionally? To build empathy is not about the facts. I've given you a lot of facts today, but the facts don't drive empathy. What drives it is narrative. What drives it is identifying with the suffering of others, and we need to do that. I'll leave you with two quotations today. Martin Luther King said, "The arc of the moral universe is long, but it bends towards justice." Barack Obama reminds us, the arc may bend towards justice, but it doesn't bend on its own. In other words, we need to be engaged in bending the arc. And so I leave you with the words of Robert Kennedy. He said, each time a man or woman stands up for an ideal, or acts to improve the lot of others, or strikes out against injustice, he or she sends forth a tiny ripple of hope. And those ripples can build a current which can sweep down the mightiest walls of oppression and resistance. It is my hope that each of you today, following the wonderful example of a sociology major from Emmanuel College, will be a ripple of hope. And together we can sweep down the mightiest walls of oppression and resistance. Thank you so very much.
That was tremendous. That was tremendous. Thank you. Yeah, that would be wonderful. We're going to start with that. If there are any questions in the audience, and I want to make clear, I've been tested for COVID twice. It really is just a cold. We're going to start with questions in the audience here, and then we'll see if there are any questions in the chat. We have over 100 people who have been watching you on Zoom.
COVID vaccinations and differences among different racial groups. I'm sure a lot of what you talked today, are contributing factors. But have you done any, new sort of analysis around that might be instructive in what you talked
Sure.
about?
There is analysis that is instructive. So, for example, the racial gap in COVID-19 is really an education gap. So if you look among the college-educated African Americans, the latest data from Kaiser, they are 2 percentage points higher vaccinated than college-educated whites. So there's no racial difference among the college-educated. So it really is a socioeconomic effect, much more than a racial effect, is what I would say. At the same time, I think across socioeconomic science is a powerful predictor. The other powerful predictor is political party ID. So the latest data shows even among Republicans, about 58% of Republicans with a college degree were vaccinated, compared to 88% of Democrats with a college degree are vaccinated. But it's the Republicans with lower levels of education, the vaccination rates are really very low. So it's the political identification and socioeconomic status seems to be really powerful predictors. One of the interesting things, I heard a talk from someone from the UK, from the London School of Economics recently, and she's been studying vaccine hesitancy globally for some time. And what her research finds is the single biggest predictor globally of vaccine hesitancy is distrust of the government. Distrust of the government and political leadership and leaders is the single biggest predictor. And she emphasizes that it's not just about the facts. In dealing with vaccine hesitancy, the first and most important principle is respect. You're talking to individuals who distrust the system, who are alienated from the system, and if you talk down to them and act as if they're stupid, you certainly are not going to make any progress in dealing with. So respecting them, trying to understand them, and listen to them. And she also emphasized that one of the appeals that is the most powerful is to protect itself, to protect your community, to protect others is one of the most powerful appeals. But it was a really intriguing talk about the extent of alienation within our society. And this is a global phenomenon. This is about across, I think she described the study in 40 different countries, and the same factor emerges every single place. So how we approach people and how we talk with them and how we listen to them and respect them and understand where they're coming from. And yes, try to share facts and information, but it's not just about facts and information. It's first about respect and listening to what they have to say. I saw another hand. Yes.
Sorry, I forget the name of the housing project that you mentioned, but the one with the 90% of families affected by a felony every year.
Yes, purpose-built communities, yes.
I was just wondering what exactly were the changes that were implemented in the community that resulted in such a dramatic shift? Because if I remember correctly, you said that the original statistics were from 1995, and then the later ones were from like the mid-2010s. So
Sure.
I was just wondering if it was a intervention like from within the community itself, or was there an external factor that affected this, or what was it?
So it's a really great question. It took the government, a wealthy entrepreneur, and the community working together. So what happened was a wealthy entrepreneur who was interested in purchasing a golf course that was nearby drove through the community and was shocked. He was stunned that people in America were living under the conditions that he saw just driving through the community, and he was impressed that something needed to be done. He was someone who had built many of the skyscrapers that dot the Atlanta skyline, and he felt something needed to be done. And he worked with the housing. There were a group of women who were in that community in the housing project, who were a community group, and worked with the public housing department of the city of Atlanta. And they came together. So it was a combination of financial resources from a wealthy philanthropist with a community group having input and setting up the rules, and with the city of Atlanta and the state of Georgia working together with them. So it's a combination of private money with public funds and so on. What the Purpose-Built told me, I visited there a few years ago with one of my colleagues, is that they are able to operate everything they do. They're preschool, they have a new gym, they have a new high school, a new elementary school. They're able to operate on publicly available dollars. But to get started, they need the private funds. And their model includes, in any community that's going to do this, of seeking to identify private funds within that community that can come in to get the project going. But there are purpose-built communities all across the United States, in New Orleans, in Charlotte, in Omaha, Nebraska. There are purpose-built communities everywhere, and they are really spreading the model. And it shows it can be done. I think I saw a hand at the back. Yes.
You mentioned that one of the strategies is educating people about institutionalized racism.
Yes.
But we're living in an age of disinformation.
Yes.
And so, which is a kind of a counter to this need. And so I just wondered if you had any thoughts on strategies outside of the academy and, to raise public awareness about this.
You've really asked a great question. And yes, most Americans are unaware that racial disparities exist. That's been true. National polling data show that to be the case, and you need to raise awareness levels. And I would also say that although I was heavy on the facts, speaking to an academic audience, if you were working with a local community group, it would be less facts and more stories. Look at the impact of George Floyd's death. You could have gotten Shakespeare to write about George Floyd's death. It would not have had the impact of those 9 minutes of videotape. People respond to narrative. People respond to story. And so what's really powerful is to begin, and you can find all kinds of stories online on YouTube illustrating racial inequities and illustrating racial discrimination, that I would begin with a video and or some videos and let people see it, and then let's back up and how do we make sense of it? And then you give them the facts to help them to understand how do we understand this kind of perplexing situation. I think when I speak to community groups on discrimination, I always show John Keonis has, what would you do? He has a number of excellent ones. There's one about a bike theft. That's really very powerful. You look at how do people react when there was a young white male stealing the bike, or when there was a black male stealing the bike, or when there was a very attractive white female stealing the bike. And men were rushing up to help her steal. The same people who were attacking the black male the minute he showed up to steal. And then how do we make sense of this? And it opens the opportunity to talk about what do we know about implicit bias, what do we know about these factors, and so on. So that's what I would say, narrative. Draw people into a story and then help them to unpack it. And that's when you share the facts and information. If you begin with facts and information, their minds close because they know the facts already, they think. And so it's the story, narrative is where the power lies. Great question. I think there was yes?
So you talked about the unconscious bias that is in the healthcare setting. And I wanted to know if that proves the impact of how subconscious.
If what?
That when you discussed about
Yeah.
healthcare setting and how discrimination is proven through this unconscious bias.
Yes.
Does that prove in the subconscious? And if so, does the subconscious drive over facts, our way of our actions, and how to show empathy? Or is empathy just like kind of like a chemical imbalance, and how much empathy we show towards other people?
Okay. No, empathy is not a chemical imbalance, I would say. We know that. It is linked to socialization. It is linked to what we've been exposed to. So for example, this is the studies that have looked at this empathy, and they were not looking. You find empathy with self-reports of empathy. By the way, it's not only that we lack empathy for blacks. What the research in the United States shows, just to tell you some of the work in auto psychology about empathy, the average American has more empathy for what happens to a puppy than what happens to a human being of any race. That's what the study showed. We care about what happens to a dog, but
You can see it on the news every day.
So what I'm saying is, a lot has to do with our socialization in terms of empathy, and there are programs, I haven't talked about it today, but there are strategies that help people to step into the shoes of others. And again, narrative becomes important, the story becomes important, and studies in psychology shows that the same facts, by changing a few adjectives, changing a few descriptors, one version of this story produces empathy and the other version doesn't. So it's really of how do you get people drawn into the story, drawn into the experience, and to feel the pain of others, recognizing that there are some major blocks that we all have linked to our socialization. Yes?
So there's a very related question that's come through on the chat. Even though I said I would let everyone in person go first, but I'm going to read this. What specifically can be done around the ages of 5 to 7 when caring for children to keep the empathy gap lower, to maintain the empathy that exists? How can we teach how to identify with the struggles of another racial group?
Right. That is really good, and the answer is clear out of the data, it's clear out of studies of desegregation of schools. Interracial interaction at a young age is one of the predictors in these studies that the people who had a lot of interracial interaction at a young age don't have the empathy gap. That was one of the factors on the slides. It's socialization matters, the extent to which from childhood you learn to interact with others in a positive, friendly manner, that carries over into adulthood. So that would be one thing that has shown to be very effective is early life interracial interaction. I think there was one other hand in the back, I thought I saw. Oh, okay,
I'm South African, and I grew up during apartheid in South Africa,
okay.
and learning the horror of segregation and keeping pockets of people, blacks away from each other, so that there was no way for them to interact, even know that they were the majority in the country, was by design and pure evil. Once apartheid fell, there were a couple of politicians that were always saying, for us to move forward as the Truth and Reconciliation Commission, we need to imagine a new reality, and for that we have to come together to reimagine it together, which is what I think post-apartheid South Africa was struggling with, incredibly so, because still coming together as that many groups, it's very hard, it takes a long time. As we are a small college here in sort of the middle of Boston, but it's a very small experience, what can we do to reimagine, what do you see at other colleges that are doing so well in reimagining this state, even though we're still half isolated from each other, half on Zoom, half here in person. Are there any programs that you see at universities that are particularly effective?
That's a really good question. I don't know that I know all what's happening at the universities. I know more what's happening in the healthcare space. What I would say, but by the way, I have spent a lot of time in South Africa. I've been there almost 20 times. I directed the first national study of mental disorders in Sub-Saharan Africa in South Africa. Looked at including the impact of human rights violations during apartheid and how that affected the mental health of South Africans today. And I still am doing work in South Africa, so I love that country very much. But see the real challenges South Africa faces. But what I would say, someone asked me, I gave a talk recently, and someone asked me an unusual question. They said, if you think back over your career, what are you most proud of? And my answer was, and I'm answering your question indirectly, my answer was the students and postdoctoral fellows that I have trained, that I've worked with. I am so inspired by my students. They are less tolerant than I am. They want to see a different world. They want to work for a better world. They are so committed. That is an enormous source of inspiration. And what I would say, the biggest thing I think colleges and universities could do is bring students together. They are idealistic. They want to see a better world. They will work for a better world. We need to create the opportunities and let them fly and let them come up with ideas that they could make a difference in the communities in which they work. There was a Harvard undergraduate, I knew her, Rebecca Oney, that she was concerned after volunteering at the healthcare facilities in town, and she developed a program that was called Project Health, and the name changed to something else, where she would take undergraduates, and I would have my undergraduates in my class. I teach an undergraduate course called Poverty, Race, and Health, and I would have them volunteer with this Project Health. And what they would do would be stationed at next to the admitting desk at a little table at some of our hospitals in Boston, and they would screen people. Do you have needs in housing, in food, and so forth? And what the job of that student was, is when they identified a client with a need, it was their job to link them with a resource. And the last day of class, I would have my students testify about what their experience was. And for them, brilliant undergraduate students at Harvard, they were so frustrated. Here was someone in need. Here is a service to help that person in need. Linking the two of them was so hard. And it took so much time and so much effort to link them. But they did it because they were tenacious, they wouldn't give up, and they would link them. So it's just one example of releasing the creativity of students and giving them a structure. And one of the things I was impressed with the program is not only the students got a little orientation and were sent out, they had to commit to a weekly session. One night a week, they would, I don't know if it was an hour, 2 hours, to meet, to learn how they could be more effective in the work that they did. So I think there's enormous energy and wisdom in our youth And it's like, how do we harness that power and create the opportunity that they know we would support them as older persons, as faculty and staff, to in fact take on some of the challenges we face in our society.
All right. Well, again, Dr. Williams, thank you so much.
Thank you so much.